Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you chose to spend this time with us, and we are very excited about our speaker and topic today. I can tell you that I see evidence of the need of more people hearing his talk every single day as I do my day job. Without further ado, I'm going to turn things over to our founder, Dr. Randall Morgan. Yeah, Dr. Randall Morgan started us. No, Dr. Randall Maxey.
Dr. Randall Morgan is a good friend of mine. He was in the class 2 years ahead of me at Howard. He's a great guy and a leader and executive director of the Cobb Institute. But I want to start off today just asking for prayers for one of our key advisory members who served in office as our chair of that group. And he has a health challenge and is hospitalized at the moment. We just ask for prayers for him and all others who are in need of the help of our Savior in Jesus Christ. Our topic today is amputation prevention. And we know that lower extremity amputation is performed to remove ischemic, which means not circulating well, infected limbs, dead or necrotic tissue, and for unresectable tumors that may be there. At times, the operation can be life-saving. So one of the main causes is peripheral artery disease, a disease of the circulation of the extremities. And we know that that is the leading cause. The second leading cause is trauma, or when it's been injured. But there was a paper that came out in 2003, put out by the National Institutes of Medicine, that showed that of all of the people that get amputations, all of the people that don't get the correct heart operation, the people who get castrated, the people who have the worst outcomes are Black. So it's very important that we have physicians that are disciplined in the way to save these limbs when possible and appropriately diagnose and treat them. And we have as a speaker today one of the leading experts in that area, Dr. Edwin Kendrick. And as we said before, he is the president of the Charles R. Drew Medical Society, which is an affiliate of the National Medical Association. He's a vascular surgeon in private practice. He's the founder of the Sano Vascular Group. He completed his vascular surgery fellowship at the University of Maryland Medical Center. His general surgery training was done at Tennessee, at Memphis, and also at Morehouse. He also has an MBA, so it means he can count some nickels and loan me some. He also has an MBA. He's an accomplished physician, and we invite him with joy to the Black Health Trust. You have the floor, Dr. Kendrick.
Thank you so much, Dr. Maxey, for having me, and to Black Health Trust for having me. It's an esteemed honor whenever you're invited by Dr. Maxey to come and share insights with the community. I feel that it is not just an honor, but it's a responsibility for me to do this in settings like this, as well as in the community. I want to thank everyone for coming, and I'm here for you. That's number one. Number two is that I hope that the information that you obtain today is actually dispersed within the communities that you live with, family members, because this is information that's not going to be easily disseminated, but it's information that we need to know about. And so just give me a moment and I will bring up my slides in just a second. But again, very grateful for the opportunity. I also see people that are all across the nation here, and I want to recognize people that are in Florida and New York. I think people mentioned Tennessee and or Maryland, and California, of course, and people that's also affiliated with the Charles R. Drew Medical Society. But I do want to thank everyone for coming out today. So we'll go ahead and get started. Again, what you'll see is the logo down at the bottom, Sano Health Farm, which is a nonprofit for advocacy, research, and mentoring. And there's a lot more that you can find out at sanohealth.org and some of the work that we're doing across the US. But today we want to talk about prevention of unnecessary amputations. The goals for this talk are several. Number one, we want to define peripheral arterial disease, or shortly we refer to as PAD, for peripheral arterial disease. I want you to know what the PAD risk factors are. We want to talk about reasons for amputation. We then want to talk about how to detect peripheral arterial disease. And then the last part, we'll talk about misdiagnosis and myths that can cause harm when it comes to arterial management. So this is how we begin, right? On the left side, this is what we love. We want to see a blood vessel here, has 3 walls to it. You can't see all the walls, but there are 3 walls. Here are red blood cells, and they're actually traveling through a healthy blood vessel. So this is where we start. Our goal is that we don't want to end up here, but all of us will at some point develop this yellow stuff here. This could be plaque, it could be calcium, it could be old fat that has been there, it could be a lot of different things, which we'll talk about. But the problem here is we don't want to end up where all of that yellowish kind of material gets so narrowed that it stops blood flow from moving through the blood vessel. Dr. Maxey talked about ischemia, and what that is because these red blood cells you see carry oxygen. We want to make sure that that oxygen gets through these arteries that are carrying blood flow to things like the fingers, the toes, as well as the brain, as well as blood vessels to the heart. What this does is reduce our risk for needing an amputation due to dead tissue, needing surgery on our neck, and also decreasing our risk for stroke and heart attack. So what we're talking about again is where we begin and where we start. Now, one of the important things that you'll note is inside of this blood vessel, here's where we start, but here's where we actually are. You can see again the red blood cells here, but you see these yellow little dots here, okay? These yellow dots can actually, or circles, can symbolize anything from sugar. So people with diabetes, you can have excess amounts of sugar floating in your bloodstream. It may resemble fat. So this could be high cholesterol that could be in a person. It could resemble chemicals, such as people that smoke or vape, get all kinds of toxins. It gets inside their blood vessels. So it could be a number of things. Most importantly, it could be inflammation. You say inflammation? Absolutely. So inflammation can also cause problems because we know that if you have high blood pressure, or people that may have rheumatoid arthritis or lupus or scleroderma, any type of rheumatological disorder, you can have factors floating within your bloodstream. And all of these little yellow circles, right, what they symbolize can actually cause injury to this red wall that you see around here. And over time, those repeat injuries, long-term, can result in things like collection of fat, long-term calcification. It may result in so much inflammation that you narrow this blood vessel, and so it will clot, or it can completely become blocked, or what we call occluded. Now, if this was to happen late term, remember I said that these red blood cells that you can see with the green arrows carry oxygen. So now the oxygen is not able to get through this blood vessel because of all this chronic inflammation, scarring, and damage from all those chemicals and other items that you see here in the blue. sugar, fat, chemicals, and inflammation. So our goal is we really want to be focused on this area, because if we can focus on this area and control this area, our hope is to maintain a healthy blood vessel so we can avoid this end disease. One of the things that you'll notice at the bottom of some of these slides is I say PAD progresses with age and health condition. And that is something to remember. Again, these are the health conditions, but no matter, as we continue to travel through life, with age, we have a higher risk on developing what's over the right side of the screen. Again, a little bit more background information before we delve in. Here's what we're talking about. Our ability to control risk factors that we talked about earlier. The number one way we can do that is if we don't have any health conditions. And in California, where we tend to see a lot of people on supplements, they'll even take supplements, whether it be turmeric, to try to decrease inflammation in the body. Number two ways we can maintain this kind of state is to control our health condition, whether it be diabetes, high cholesterol, so taking our medication, keeping those disease processes under control. That includes borderline diabetes, right? Because we know that even with borderline diabetes, you're still at risk for developing complications related to arterial disease, which could be stroke, risk of limb loss, risk of heart attack, risk of kidney disease. And so most importantly, how we can also maintain this state is with an earlier diagnosis. If we can diagnose someone earlier that has this kind of condition, we can try to maintain their blood vessels looking like this rather than moving over into a later stage where you start getting the fat, the calcium, the clots, and the blockage. When we start talking about late stages, it often can be from a misdiagnosis. Someone that never got the diagnosis of arterial disease or the narrowing in the blood vessels. It could be due to someone never ever receiving treatment or getting treatment too late for their diabetes. Maybe they had their diabetes for 10, 15 years and it was just uncontrolled and they didn't know they had it. Or it could be someone with a known condition that is just not controlled. And so it's also very important that if you're having health conditions, don't just tolerate that your blood sugars are out of control or your high cholesterol is out of control. We have to be active in making sure that our providers are getting our health conditions under control. Now, what we know about diabetes, Anthony Anderson, an actor who's actually a spokesperson for Novo Nordisk, they've advertised up to 4 times a greater risk of having a heart attack or stroke with diabetes, and we talked about why. We also talked about high cholesterol, and you can see again, normal artery all the way to an artery that becomes very narrow. Again, circulating high levels of cholesterol. Smoking, the toxins from that causing the same problem. And again, we talked about hypertension, we talked about inflammation. So again, normal artery wall, you get inflammatory cascades or inflammation inside your blood vessel, those circulating yellow circles we talk about, it starts to damage the blood vessel, and that's again what you get, whether it be hypertension, whether it be rheumatologic problems, like you see someone that may have lupus or rheumatoid arthritis, all right? These are all problems that can result in problems with your arteries. So the question when we start talking about road to saving limbs is there's 2 different pathways we can take. There's the easy street, which many times can be the shorter route towards an amputation, or the better way, right, which can lead us a longer pathway to avoid amputation as much as possible. And it's not just amputation, it's saving lives. That's why we put here saving lives, because most of what we talked about so far has been saving lives, not necessarily limbs. What's important is if you look at the communities around the world, does anyone know what the most common cause of death is? It's actually cardiovascular complications. And so that's heart disease. You can put into their stroke, okay? And so kidney disease, kidney failure, these are all problems that stem from hypertension, high cholesterol, and those other risk factors we talked about. So if we talk about amputation, what are the most common reasons for amputation? Well, let's see. Foot infection. That's one of the most common causes, and particularly in patients that have diabetes. So you may see family members that may have little cracks or fissures in their skin that you think may not be a big deal. But if these get infected, this can even be over the base of the foot, where the great toe is hitting against and callus against the concrete or the bottom of the shoe. This can cause little cracks and fissures. And if these get infected, many times the patient may not know. This is a good reason why we talk about diabetics, because they have a low immune system, so they're more prone to infection. We talk about checking their feet, because this is one of the most common ways that we see infections, and it's in diabetes. And many times the person with diabetes don't realize they have an infection until it gets too late. And by that time, when they show up at the hospital, it's usually in the worst stage, and it's difficult to save them. So being able to assess your foot, getting good foot care. What I recommend a lot of times is people that are prone to having ulcers or sores on their toes probably should start using some really cushioned shoes. I prefer Crocs because it doesn't tend to put a lot of pressure on the front of the toe. But having a good orthotic, so talking to a podiatrist about something that can fit in your shoe to stop excess pressure on the foot is important, as well as stopping your toes from actually being injured by being in very tight shoes. Here's something called rest pain. Now, what we're talking about is arterial disease. And again, in arterial disease, well, let's say, first of all, why are we even talking about arterial disease? The reason we're talking about arterial disease in an early diagnosis is because if we can detect the narrowing in your arteries in the legs, that's usually the most early sign that someone has a risk: heart attacks, strokes, kidney failure, okay, and then loss. So by detecting the disease sooner in the legs, we can often put people on risk factor modification. But in rest pain, this is a late stage. This person already has severe narrowing of their blood vessel. And so when they're lying in bed at night, the reason we call it rest, because that's what you usually do in bed. And in bed, they may have cramping of their toes, cramping in their foot, and they may have to dangle their foot off the bed and massage their feet to try to get relief. So this is a more severe stage of peripheral arterial disease. And if you start to get sores, it's a critical stage where these people need surgical intervention as soon as possible. So you have rest pain, this is a serious sign, and many times these patients need urgent surgical intervention, particularly with sores. What you also see underneath that finger is a little bulge, okay? And we'll talk about that. And matter of fact, this looks like the skin of a Black person. So we'll talk about that as well. But I want you to notice that rest pain, I want you to notice this looks like a varicose vein here. I want you to notice some swelling around the ankles. And we'll talk about this in just a little bit. What's going on? All right, claudication. Now, oftentimes on television, it's like, can you really trust what you see? On television, when they talk to us about arterial disease or narrowing in the legs, they often talk about claudication. What they often say is if you have symptoms of walking and you're getting cramps and pains in your legs that require you to stop and rest, you may have PAD. And if you do, go see your doctor. And so here's someone that's actually walking, they're having cramps in their legs, they need to stop, they recover, their legs feel better, and they tend to walk again, probably about the same distance, and they have the same condition. That's called claudication. The question is, people with claudication, do they need surgery? The answer is, most times they do not need surgery at all. Now, I want to say that again. People that are diagnosed with claudication, do they need surgery? Again, Oftentimes, they do not need any surgery at all, and they actually have the lowest risk for amputation despite them having cramps in their legs. I'll say it one more time. Do people with claudication, do they really need surgery? And the answer is no. Why? Because we know that the people with claudication, if we put them on risk factor modification, that means medication management. Maybe it's cholesterol lowering medications, medications that decrease inflammation, and they actually have a healthy diet and exercise. Their arteries will actually start to increase in size, delivering more blood flow to their feet. And so they tend to be able to compensate for the narrowing in their arteries. These patients, again, are at the lowest risk for having an amputation. So the question becomes, well, I know a family member that had this very problem. Why did they get an operation? Well, I'll tell you. The main time that we operate on people with claudication is because they have difficulty moving around, maybe doing daily activities or working. So if you have problems shopping in the grocery store, you have problems moving around your house, you can't do activities of daily living like cooking, all right, cleaning the yard, that may be a reason why. Also, if you're working and you can't walk, you need to walk at least a mile a day, but you can barely walk a block, that's a reason to have surgery. But outside of that, these patients really do not need surgery. And as a matter of fact, outside of the medication management, that also includes a medicine that can actually double your walking distance. So there's a medication we can give to people that can make your red blood cells a little slippery, and you can actually increase your walking distance over time. And we talked about by increased exercise, you can dilate the veins, dilate the arteries. Now, I have a very good example of this. I had a patient that came in with claudication, and she actually mistook the information. I said exercise 3 times a week for 45 minutes a day, and she thought I said exercise 3 times a day for 45 minutes. Well, by the time she came back in, guess what happened? Her symptoms were gone, okay? And we see this all the time. So this is something that's actually feasible. Now, here's the problem. The reason why I talk about it is based on this cartoon here. The doctor asks the patient, says the patient, all your labs are back. They show a serious overuse of unnecessary and inappropriate tests and procedures. This is what we see in claudication. We see a lot of patients with claudication who are undergoing unnecessary surgery, surgery they do not need. Now, let me ask you a question. If you have a blood vessel that is intact, meaning that blood flow is flowing through it still, it's getting through, maybe a little difficult at times, but it's getting through. Now, what if you go sticking things, wires, and you're tearing up the artery to try to open it up and putting stents in place? What do you think is going to happen? At some point in time, with all that injury to the blood vessel, we know it's going to scar. And that scar inside the blood vessel over time can start to narrow it again. And so every time you undergo a surgical procedure, there's always the risk that it could get worse and lead to, guess what, an amputation. And what we said is that our goal is to not take the easy street. We want to take the better way. And the better way is making sure that if you have claudication, before anyone touches your legs, you have to make sure, are your symptoms inhibiting or stopping you from doing activities of daily living or either working? If they're not, be very cautious about undergoing procedures. Now, here we go with a lot of Black people on this. All right. And the question is, why do I show them and why do I show atypical? The reason I show atypical is because most Black people have either no symptoms, which we believe are actually atypical symptoms, or they're having symptoms, but it's not the usual symptoms we talk about. They're not having claudication or cramping in the leg that actually happens with walking and then improves with rest. They're not having those. Many times, Black people also don't have pain in their feet and cramps in their toes where they have to dangle their legs. They're not having that. So what kind of symptoms do they have? Does anyone know what this is? Do you remember earlier I said I pointed out a varicose vein? Here's a varicose vein here. These are other spider veins that's actually on the feet. Now, the reason I share this is because this atypical pain / no pain is actually because they're having symptoms related to another condition. And so what happens with varicose veins is the blood starts to pool in the leg. And if you think about carrying weights around on your leg, no one wants to walk with ankle weights all day unless you're an athlete, right? And so what happens is your legs start feeling heavy. They can feel tired. Their ankles can get swollen, okay? You can start to have other symptoms such as burning, numbness, tingling in your legs, because all that inflammation, that swelling in the leg starts to damage even your nerves, okay? And so varicose veins have often been shown in my practice to be associated with peripheral arterial disease. As a matter of fact, when I looked at 80 patients in my practice that actually were diagnosed with arterial disease, about 74% of them, and the majority of them were white, actually had venous disease underlying the arterial disease. So it's important to know that just because you have arterial disease doesn't mean that you don't have another condition. Another condition that can be commonly associated with arterial disease or can be a misdiagnosis is pain. So here we have bones of the spine, we have a disc, herniated disc you hear about. Sometimes that disc can impinge or push against the cord. Sometimes the nerves leaving the cord can get harmed by bones surrounding it, and it can result in pain, burning pain shooting down the back of the thigh, back of the calf. Now, some doctors may say, wow, you have arterial disease. You may not have arterial disease. It may just be sciatica. But again, in some patients that may have had a car accident, some injury where they were lifting a lot of weights, old football injuries, athletics, they may have sciatica that's also associated with arterial disease. So we don't know, but we need to know that atypical pain or having no pain does not mean the person doesn't have arterial disease. They may have it, they may not have it. So again, in Black people, we're seeing symptoms that aren't always the traditional arterial disease symptoms of claudication or rest pain. We hear about diabetic neuropathy. Just because someone has diabetic neuropathy, and yes, you can see this person has varicose veins as well. Many of these symptoms, whether it be arterial disease, overlap venous disease, or vein problems, overlap nerve problems. And what you can see is many of these symptoms are the same. And so it really have to be with a provider that understands this and is not misdiagnosing someone. It's not misdiagnosing means they're giving you the wrong diagnosis, and it's not a misdiagnosis means you have arterial disease and they just haven't diagnosed you with it because they haven't taken the time to do the correct examination. So again, we're talking about Black people in particular. We fill up a lot of this group of atypical pain, and that becomes related to vein problems that can overshadow or mask presence of arterial disease. Sciatica can do the same, as well as diabetic neuropathy. Now, why is this important here? Because you have someone purple, because guess what? They've been treating everything in the patient except for what needs to be treated. And we want to make sure that as Black people, that we avoid being the purple man in the bed or the purple lady in the bed. We want to make sure that we're getting the right diagnosis and the right treatment. So now the question is, why do we need to detect the disease? Now, I actually gave this away earlier. I said because the first place that we usually detect the disease earlier is where? Is it in the neck? No. Is it in the heart? No. I said it's in the legs. Again, where's the first place we usually detect the disease earlier? It's in the legs. So if we can detect the disease in the legs sooner, we can start people on risk factor modification. That is diet, that's exercise, that's making sure we can control all the risk factors of diabetes, high cholesterol, rheumatology problems, hypertension with medication management, okay? And nowadays, we're talking about Ozempics, right? and Rybelsus and all these new medications. We're talking about those medications reducing inflammation in the body. And that's where we are now. So how do we take disease in the legs now? So I know we have some physicians here, and they're going to tell me, they're not going to tell me ultrasound, they're going to tell me to put some blood pressure cuffs on something. And they would be correct. We put blood pressure cuffs on the arms, and we put blood pressure cuffs on the ankles. And the reason we do this is we want to compare the pressure in the arm to the pressure in the legs. And by comparing the pressure, it lets us know if there's a drop off in blood flow anywhere between the heart and where we check the pressure. The blockage could be here in the aorta, that abdominal artery. It could be in the artery that leads to the legs, the iliac artery, or it could be in some of these leg arteries, okay? So this allows us, the blood pressure allows us to detect the changes between the arm pressure and the leg pressure. What you see in the left column is actually how we do it. It's a math problem. So to check the pressure, the index, that's what we want to get, the pressure in this leg, we take the highest right ankle pressure and we put it over the highest arm pressure. Again, if we want to do it, the left ABI, this is the ankle, the arm, the ankle, the brachial, B is the arm, brachial is the arm, so the ankle, arm, index. And by doing that, it'll give us a number. Now we know that the highest pressure tends to be in the leg. So let me give you an example. Let's say that Ms. Johnson had a blood pressure of 135, top numbers 135 in the arm, but in her legs, the pressure is 62. Like, wait a minute, that's a large drop in pressure. Why would her leg pressure be 62? Or let's make it easier. Let's say it's 20. Well, Miss Johnson has some big problem where the blood pressure is too low in her legs. So she must not be getting blood flow through. That's why we use this calendar. That's why we use this chart. So if the blood pressure is too low, usually less than an index of 0.9, so you put the ankle pressure over the arm pressure. If it's less than 0.9, or Miss Johnson with a 20 pressure and 130 in the arm, she'd probably be here with severe disease. What this suggests is you don't need to compress this blood pressure. You compress it just a little bit, it's going to close off her artery. So that means she's not getting just a trickle of blood flow in there. But now let's look at the other hand. On the other hand, if Ms. Johnson's pressure is 130 here in the arm, but her leg pressure is 260 here, or really 250, right? You'd say, wait a minute, Ms. Johnson's pressure is so much higher in the leg. Are her arteries just that much larger? That it just takes so much pressure to constrict it? The problem is Ms. Johnson may have all that plaque. Remember that yellow stuff I showed you that was narrowing the artery? That's what she may have. And now that calcium can turn to almost like bone, that calcium. And so now it's like compressing a steel pipe, and it's hard to compress it. It may get to the point that here it says non-compressible. The arteries may be so damaged with plaque and calcium that you can't compress it. And this means the index is going to shoot up greater than 1.3. And we're going to say, Ms. Johnson, there's a problem here. You probably have very bad disease, and there's a problem. There's possibly a risk that if we don't get this resolved, you can be at risk for amputation without good medication management. Now, here's a problem, though. There's a problem. The problem is that this does not work in people with diabetes. Okay? I'm going to say this again. This does not work well in people with diabetes. And you ask, well, why doesn't it work in people with diabetes? Because their vessels tend to be very heavily calcified. So let me ask you a question. If the vessels are really heavily calcified and it takes forever and you can't compress it, you can't do the study. You have no idea what the problem is. Now, let me ask you another question. Do you believe that the vessels can be so calcified that they almost are so narrow that you can then just press it a little bit and it closes the vessel off? Absolutely. People with diabetes may start off normal. They move into what's an incompressible vessel, means it's just so tight to compress it. and then they go back down to normal, and then they move into where you can't get any blood flow through. So with them, it's almost like they go up into non-compressible, then they come back down into normal, and they come back down into severe arterial disease. This is why you cannot rely on an ABI in patients that have diabetes and also kidney disease, because kidney disease and diabetes tend to affect these lower leg arteries. Again, should we rely on an ABI, an ankle pressure in a patient with diabetes or kidney disease? No, we should not. So again, ABI is not and should not be used in patients with diabetes and kidney disease, because if you catch someone that has been in non-compressible and they're now back down to normal, you're thinking they're normal, and then 6 months later, guess what they have? Severe arterial disease, and you missed it. We don't want to do that. So how do we detect it? I'm glad you asked. Guess what blood vessel is one of the last ones to get heavily calcified? It's the toe arteries, or the digital arteries. So these toe arteries are smaller, and they tend to be the last blood vessels to get heavily calcified. Again, heavily calcified vessels mean it's hard to compress them. So we want to compress vessels that are not heavily calcified, and we can do that many times in digital arteries or toe arteries. And so any study that you get from your doctor, okay, if you have diabetes or your family member has diabetes or kidney disease, you tell the doctor, no, sir, I have been educated by a vascular surgeon, and he said that you need to add on a TBI. So if ABI means ankle, brachial is the arm, so ankle, brachial or arm index, ankle arm index, then what's a TBI? Toe, B is for brachial or arm index. Okay, so if you want to call it in your terms, I want an ankle arm index. You want to say that because you don't remember the word brachial? Then say it. I want an ankle and I want an arm index. If I don't have diabetes, or my family member does not have diabetes or kidney disease, but if they do, you want a what? I want a toe arm index. Okay, toe brachial index, or TBI, or a toe arm index. Okay. Now, I gave you a lot of information. Now, the question is going to be, as we get ready for the quiz, how much information you actually retain. I think you're going to do very well on this quiz. I really do. So here we go. Common errors in detecting disease. So let's go with the patient with diabetes. Let's look here. Patient with diabetes. Should we perform an ABI on them? We should not perform that. You guys are doing so well. You're doing so well. And why? If you look really closely at this image, you can see something there that looks like a linear structure. See that line? And you see all that white there? Look here on the back of the ankle. Again, you see a blood vessel. You see all this white. What you're seeing is calcium that's inside. Remember I talked about that steel pipe? Okay, trying to compress that with a blood pressure cuff is going to be very difficult. And so again, what we see is calcium. And that calcium, it can show that it's normal. It can show that it's non-compressible. It can then go back down to normal, and then it can drop all the way to severe disease. So again, in the patient with diabetes, kidney disease, we don't want to use the ABI because of the calcium problem. It's a calcium problem. Okay. Again, what do we use? We use a TBI, all right? A toe brachial index or a toe arm index. That gives you a greater detection for PAD in persons. Why? Because what is the blood vessel that gets the least calcified? The toe arteries. And again, that's why we check it. And who do we check it in? Kidney disease patients and patients that have diabetes, because it avoids a delay in diagnosis and treatment. What do we want to avoid here? A misdiagnosis, okay? So your family member goes to the doctor says, I want to perform an ABI, they have diabetes, kidney disease. You're going to say what? not without a TBI, okay? We want to make sure we don't have a misdiagnosis, doctor. So add the TBI on there. Ultrasound. Now this is a big quiz question here yet. We haven't really talked about this. Ultrasound. Now what's happening in the Black community in particular, in all communities, is that there's a push for only doing an ultrasound on patients. Okay? Now, if you do an ultrasound on a patient, what we're looking for is narrowing of the blood vessel. And the way we detect narrowing of a blood vessel is we can sometimes look to find an area of narrowing, okay? Or we can look for how fast a red blood cell is traveling. And the goal is maybe that tells us some information about how narrow the blood vessel is based on how fast the red blood cell is traveling, because you can put something on a red blood cell, on a stream of red blood cells, you can put something on it and you can check the speed, almost like a radar. When someone is throwing a baseball and they can clock it with a radar, that's what the ultrasound does. It can clock how fast the red blood cells are moving through that blood vessel. Well, here's the problem. It may work well in people that have extremely low blood flow. It may work well in them. But the problem is that the majority of patients we're seeing are people that we don't know if they need treatment or not. So in those patients, it's averaging about 50% of the time, it may determine if you have a significant narrowing or not a significant narrowing. Now, if I ask you the question, would you want to wake up every day 50% chance you'll eat, 50% chance you won't eat? I think we want to eat as much as possible because it helps us take care of ourselves. The same kind of concept goes into how we diagnose conditions. We want to diagnose conditions with a better accuracy because it helps us take better care of ourselves. So the reason we do not screen, when I say screen, that means it's the lower cost test to determine if someone is at risk for arterial disease. The reason we do not screen with an ultrasound is we will tend to overdiagnose many times people that are in that 50%. They may get overdiagnosed with having disease when they don't have it. Remember that purple man we saw on the bed? You don't want to start undergoing arterial procedures for your legs when you really don't have the disease at all, okay? Or the disease is not significant enough to warrant surgery. What you don't know is that in the community, many surgeons, that's invasive surgeons, that's interventional cardiologists, that is interventional radiologists, that includes general surgeons, are actually performing the ultrasound instead of the ABI and TBI, are then diagnosing the patients with disease. Okay, we said what happened. Many times you'll end up saying they have disease when they don't. They don't do any other study and they recommend the patient for treatment. We'll call this the purple syndrome, the purple man syndrome, the purple man diagnosis, okay? So anybody that offers you just an ultrasound and they don't do a TBI and ABI, there's something wrong with that picture. And I would say that you probably need to find a provider that's going to give you the best assessment possible. Now, here's what you should know. If you combine these tests together, guess what? You actually have the best option overall on getting it correct. Again, ABI works great in people that do not have. As a screening tool, that's the initial screening tool. This works better in determining if somebody is at risk of the disease, except in what patients? Patients with diabetes and kidney disease. If they do have it, we want to go here, right? Toe brachial index. This ultrasound is a complementary test. It should not be performed by itself. This is a complementary test to complement what we've already been detecting in the patient. Now, when it comes to a screening tool, this is not, all three of these are not a screening tool. ABI or ABI with TBI in certain patients are a screening tool. This ultrasound is a diagnostic tool. This is for confirmation of disease. So we can start here. We can either go here or we can go to, sometimes people will do a CT scan, but other type of studies, ultrasound is not by itself a screening test, and it should not be used to screen, detect, and treat disease alone. Now, why do we need to detect disease? One, we know that, again, if we go back to the start, we said that if we can detect the disease sooner, we can start management sooner on the patients. Why? Because we want that healthy blood vessel that just has those little yellow circles that's moving through. But those yellow circles have not impacted the vessel so much that it starts to narrow it. So that's number one. Number two, why do we need to detect the disease? Well, we need to detect the disease so we don't get a purple man syndrome or a misdiagnosis. We don't want someone treating us or our family members unnecessarily. If we do, we could end up in surgery. The reason I put atherectomy devices here, and I have, I think, the medical student or two on the line, is because this is what we've been working on. We know that if it comes to surgery, first, this is the method. They are actually diagnosing you with an ultrasound. The next step is they then tell you that you need to go undergo surgery. And most of them are providing atherectomy. These devices have not been proven to have long-term sustainability in managing a patient. But guess what? We use them because the billing is so much better, okay? Even though the medical benefit may not be. And so we have to be careful because atherectomy is actually damaging this plaque to try to open it up, but it can actually injure the wall of the blood vessel, leading to, guess what? More narrowing over time. And this may actually close. And I have seen patients in my office that have undergone this procedure. One patient, every month for 22 months, she underwent surgical treatments. She had about 30 stents placed in her legs, both legs, by the time she came to see me, operating on each leg, switching months on each leg. She's now a bilateral amputee. This is a story that is happening across the nation. It is happening in my own family members. So the goal is that why do we need to detect the disease so we can start management early? We need to detect the disease and make sure we're doing it correctly so we don't over-treat patients. And so again, we need to detect disease for medication management. Okay? Question again, do we treat patients with claudication, the cramping pain in the legs if they walk and they stop? Do they often need treatment? The answer is no. People with claudication or cramping in the legs, we said they have the less risk for an amputation. And so those patients usually do not need surgery. They need medication management unless they have difficulty performing activities of daily living around the house or grocery shopping, or cooking, cleaning up, or if they can't perform their job duties. Again, claudication is separate, but we need to understand that why we do surgery. Again, we want to avoid surgery and detect the disease well. So now the question becomes, how do we protect our community? So now we understand what PAD is. We know we need to control PAD by controlling those health conditions. We know that we need to get the diagnosis sooner so that we can start that risk factor modification. And we also know we need to avoid people misdiagnosing us in the community. Well, here's how we protect our community. Does anyone know what this is? Okay. Looks like gold, doesn't it? Does anyone know what this is? Oh, now you're doing a second look. You said, oh, I thought that was gold, but wait a second. The luster here looks so much different. Actually, this is pyrite or fool's gold. This is the gold. Now, the question is, why did I show this? Because we've been talking about misdiagnosis. We've been talking about how to diagnose people right. But guess what? There is a problem that we are facing in our nation that's likely to place most Black people under the knife unnecessarily. And I call it the pyrite or fool's gold versus the real gold. How do we protect our community? Currently, if you read at the bottom, there's something called the ARC Act. It's the Amputation, Reduction, and Compassion Act. Now, on the surface, you're saying, what is this doctor talking about? Amputation, Reduction, and Compassion Act, all of those seem good. But again, what's in a name? We need to really dive deeper and understand what we're talking about so we can figure out, is this pyrite or is this gold? Well, here are the essential mechanisms of the ARC Act, which has already been introduced in Congress. Right now, it sits at a health committee to determine whether or not it's going to get passed and goes to the House. You're saying all this is happening about me? Absolutely. The Amputation Reduction and Compassion Act. Now, the person that authored this bill is no longer with us, but he's a congressman out of New Jersey. Great intent, multiple medical problems, really wanting to do the best for the community. But sometimes, even though our intentions may be great, sometimes there's a missing link. The concern that and that the Society for Black Vascular Surgeons have had regarding the ARC Act is a couple. One is the ARC Act says that we should screen, again, screening persons with PAD with an ABI. Question I ask you is, should we screen everybody that's a Medicaid patient or a Medicare patient, right? And possibly in the future, everyone that has private insurance, should we screen everybody for PAD with an ankle brachial index? Absolutely, I'm making progress. This is the actual quiz now. I'm just letting you know, this is the actual quiz. You will be graded at the end of this. So you're absolutely right. We don't screen persons with for PAD. You don't screen everybody with PAD with an ABI, and we know why. So that is wrong. We don't support that because of that very reason. This has already been proven. There's no dispute about this. There's no need to push this on our community. And what are we going to do? Misdiagnose people that have diabetes and kidney disease who could have had severe disease that went up into non-compressible. Then they went back down into normal. And the ABI says it's normal, but 6 to 18 months later, guess what? They're actually subject to losing a limb. And those are patients that may have needed a surgical intervention sooner, but they just didn't have symptoms because they had diabetic neuropathy. We have to be paying attention to what's happening to our people in our community. So we know they need a TBI. Oh, the second thing, I gave it away. I'm a bad quizzer. I just gave away the answer. I am so sorry, but some people are probably happy. So the next step is, do we screen persons for PAD with an ultrasound?
No.
The answer is no. And why don't we do that? Because that largest population of people that may or may not have significant disease may be overdiagnosed with having disease, which can lead to what? Surgery. And unnecessary surgery we'll call the purple man syndrome. Our goal is to not get that purple man syndrome by getting people to overdiagnose us with problems we do not have. Now, the ARC Act says specifically, you either diagnose everyone with an ABI or you can use an ultrasound. Now, there's nothing in the literature to ever support that. Why are we doing this? Why are we doing this? Well, guess who the pushers of this bill are? I am. Wait, I said I wasn't pushing the bill, but technically I am, because some of the societies that I'm a part of actually do support the bill. Who else supports the bill besides vascular surgeons? Interventional radiologists. Who else? Interventional cardiologists. Wait a second here. Wait a second here. Is this pyrite or is it gold? So when we go back through here, this is the ARC Act. Diagnose someone with ABI only or diagnose them with an ultrasound. And most people end up using the ultrasound. How do I know that? Because we know that ABIs are only performed in about 33% of medical practices when they did a partner study. I think it was out of Philadelphia, and they found that only 33% of the practices actually had the equipment to perform an ABI. Well, guess what? Most of them have an ultrasound machine. So this, where do you think our people are going to be? Right here. Getting diagnosed with ultrasound, being sent for surgery, and what? Ending up with a higher risk for amputation. Again, is it pyrite? Is it fool's gold? Or is it gold? All that glitters is not gold. Again, this is who's supporting the bill. Guess who has not made a decision about the bill? Primary care physicians, the American Heart Association. What our job is to do for all of us that are attending here, I said this is not about me. I said it's about our family, it's about our loved ones. Our job is to pass the message because most of us don't even know this exists. Matter of fact, most vascular surgeons don't even know that this bill exists. And I'm talking about, I've been talking to people from Hopkins. Matter of fact, one of the people that were working at the Vascular Research Consortium at UC Riverside went and published about this based upon her knowledge and understanding about what we've been proclaiming all along. This is not a bill to actually impact our communities very well. Again, it's called the Amputation Reduction and Compassion Act. Now it's not all bad. The part that is good is the last part. A vascular study must be performed before an amputation. Now that just makes sense. What we don't want is to have people performing amputations on people without actually doing a vascular study, because some of those patients may have legs that could be saved. Because what we also know is that sometimes the cost of doing an amputation is greater than the cost of actually doing an arterial procedure. And so we don't want people pocketing money on our behalf and our family members losing their legs. So doing things right because it's right is what's most important. So we say no to the ARC Act. And we say that the congressional members actually need to go back and start understanding some of the science and what's been already proven, what's in the literature out there, so we don't harm our communities. All right, so we tell Congress no. Did you pass? Great, good job. Well, guess what? That's the end of this talk. So first of all, I want to again thank everyone that decided to spend their Sunday afternoon, early Sunday evening, coming out to hear about peripheral arterial disease. I hope that this has been encouraging. I hope this has been a learning experience. But most importantly, I hope that each of you all are advocates for your family, advocates for yourself, and understanding some of these basic principles on what peripheral arterial disease is. Yes, we need to diagnose it sooner. Number two, in Black populations, yes, many times we're not diagnosed with the disease because we have other factors that's happening. But if we start getting screened for the disease, we have to do it right. We cannot take shortcuts in our community with healthcare, because what that will do is lead to further amputations. It'll lead to further compromise where people can't be independent anymore. People ask me, why did you end up in vascular surgery? Well, guess what my first case was when I was a fourth-year medical student? The first case I got to do, pushing that general surgery resident out the way when I was operating with attending, was an amputation. And it was bittersweet because this is the first case I got to do without a surgical resident around me with the attending. But the problem was that it was in a 92-year-old Black female named Miss Brown. Miss Brown was independent, functioning well, walking well at home. But Miss Brown, by the time she came in to see us, had such severe disease in her leg that her leg was not saved. Made me wonder at that time, Miss Brown is now going from independent to dependent. How much is her life going to change? And so there are consequences for us as surgeons operating on patients. That's a serious consequence for many family members that starts to touch more than just that patient. And so my hope is that this talk creates in all of us advocates a way to get this message out and to be able to support. One of the things that we will be doing, Sano Health Arm, advocacy, research, working with medical students, mentoring medical students, high school students, all the way to from pre-K. Our goal is all the way up through postgraduate training. Our community has to come together to understand that we all need to advocate for better care and be supportive of lifting each other up. So in New York, around the NMA convention on August 3rd, we have people from St. Luke that will be there. St. Luke Church is sponsoring this, hosting this for us. But many organizations are coming together to provide free PAD evaluations in the community. Okay, and there's a method that we do it. It's not ABI, TBI. We're listening to signals and then directing people to actually get screened. And so one of the things we're doing is trying to get education, awareness out there for people. This needs to happen around the nation. And I look forward to being as supportive as we can. But if you're in New York, it's August 3rd at St. Luke AME Church. And this is something that happens in Southern California. And my hope is that this was beneficial to everyone today. And thank you again, Dr. Maxey, for having me. And it's a pleasure and honor to be here. Thank you.
Thank you very much, Dr. Kendrick. I'm going to name you officially the professor of the community. This was great, excellent, and I learned a lot, and I'm sure everybody on the line learned a lot. We're at the top of our hour. I'm going to ask our moderators to see if there's any questions in the chat, and let's just spend a few more minutes discussing what Dr. Kendrick so well put. This is very important. I hope people did learn a lot. Dr. Hines.
So thank you. I have to second Dr. Maxey's point about having learned a lot as a family physician by training, to your point about the primary care doctors and not being able to do ABIs because we don't have the tools, but our time is short. Medicare Advantage members are often getting access to in-home health assessments from their insurance companies, right? And there is a big push for point of care PAD testing as part of those. Can you talk a little bit about the TBI, ABI component of that from our own understanding? Just because sometimes there are the types where, you can clip onto your finger and you can clip onto your toe. Is that what you're referring to as a TBI? Because again, the point about, misdiagnosis or false sense of security and all of those things is critical.
Okay, that's a very good question. What she's asking is about, you can actually place a little probe or clamp on someone's toes, and it will actually give you a pulsation, all right, that suggests flow, all right, a volume of flow within a blood vessel. And the question is whether that alone is actually helpful. Well, there are conditions where you can get an abnormal signal, particularly in some patients that have rheumatoid problems. Here's what I'll tell you, is that is something that is entered the market space, that is being tested. But again, remember when I said that I'm at St. Luke Church and we're doing some diagnostics, not diagnostic, but some screening, and I talked about putting a Doppler signal and listening to sounds. Okay, very similar. The goal would be is that test is not a per se, it's sort of like a mini screening test. What we're doing in New York is a mini screening test. Those people that are found to have abnormalities should then be sent to either a primary care doctor or specialist to undergo the actual screening test, not an ultrasound, but ABI or ABI with TBI. And so that should be the first step in moving them towards. So we get a little bit closer to the bedside, which is what we need to do, a little bit closer in the home, and then directing them through health navigation where they need to be.
Thank you, Dr. Kendrick. Dr. Ivan Walks.
Thank you, Dr. Kendrick. I frequently say that my favorite word in the universe is clarity. I love clarity, and I love the clarity of this presentation. What I'm taking from this is the importance of our providers being thoughtful and being thorough. There's so much quickness in healthcare now. You've got to see this many patients per hour. You've got to see that, and this notion of every individual being worthwhile is what I am getting from this. The last little bit about Miss Brown going from independent to dependent is a huge factor. It's a huge factor in quality of life. I can rant for a long time about the importance of folks caring enough to take a minute, make that initial screening, make that referral, and make sure folks are getting a complete, worthwhile evaluation. Thank you so much.
Thank you, Dr. Walsh. Dr. Barbara Neighbor-Stephen.
Thank you so much, Dr. Kendrick. You have also educated me quite a bit and really got all kinds of light bulbs going off. I want to ask you very specifically about the ARC Act. I was not aware of the ARC Act. I feel like it's another example of us trying to legislate medicine. And as usual, it's an incomplete attempt. Now, I was curious, has there been any success in educating the Congressional Black Caucus as to what is wrong with this act?
Partially. I can tell you that the Society of Black Vascular Surgeons, i.e. me, was invited to be part of the table for this meeting, which had a lot of people from industry there, a lot of specialists. And upon visiting and noticing what was happening, went back, reported back to society. And even though politics are always present, I must say that I was so proud of our board of directors that we repeatedly, and there were multiple statements, repeatedly voted this down because we understood the significance of its impact on the community. I have started what's called the Equality Overcomes Needs Consortium, which CRDMS has been a part of and was at the founding level of that. Dr. Maxey has sat in the organizing of that as well with Dr. Richard Allen Williams. And what we've been doing is trying to build a cohesive group of persons, communities, organizations that can come together to support ways to improve care access and delivery. So letters have been sent to members of the Congressional Black Caucus. Letters have been sent to congressional members that actually have been sitting on the Health Committee. Our goal, however, is to get more organizations, particularly primary care, involved. Our goal right now should be, before we talk to the Black Caucus, Congressional Black Caucus, is to get the family physicians, Black family physicians, internal medicine. We need to get people that really are seeing the patients on the front lines to understand what's happening. We need to come together to the table to talk. That's something that I'm interested in doing. Dr. Maxey, if you want to talk to Dr. Maxey, we can arrange to have, these meetings of the minds of these major leaders of these organizations. But that's what we really need, because when I talk to the congressional members, they want to know who all is in support of this. And so the greater amount of support, then we can start talking about getting that together. There is a CBC, I think, coming up September 11th of this year. I think we're going to be dealing more so with residency related issues for the EON Consortium, but that is something that I really do think we should participate in. I look forward to hearing more about it as we can coalesce.
So we have a time limit, but this is so important. Let me give you a couple of suggestions if you would consider them. The National Medical Association is coming up, and there's a board committee called Health Policy. And they usually present their report to the House of Delegates. It's probably too late to get something to the House of Delegates. But if you can give us a short paper on this to the past President's Council, I think we're allowed to bypass that and get a vote on that. So you should call me about that and I'll get it to Dr. Penn. Also, I just got an announcement that Representative Sheila Jackson Lee passed, and she's been one of the people that has fought for Black health a long time. She just passed, I think, yesterday or today. And I mentioned before, we want a prayer for other people who are in serious problems. So we thank you again, Doctor, for being so helpful and clear on information. And we want to invite you back. I really liked your presentation so much and your sense of humor. Have a great day, everybody. Thank you very much, Simon. Have a great Sunday afternoon, everybody.
Bye.